Welcome everyone to the 2025 Super Bowl of Debates brought to you by the American Society of Pain and Neuroscience. I'm joined tonight by Dr. Dawood Syed and Dr. Timothy Deere. We've got an exciting program for you all tonight. Hopefully we're going to learn a lot and keep an open mind and change some views. I'm fairly confident of that.
Thanks, Chris. Thanks for putting this together, in your new role as leader of our educational events virtually. So this is something that we've put together now. I can't even keep count, but I think we've been doing this since the Chiefs started their Super Bowl run. That's the easy way for me to remember it. I think the first one might have been when Tom Brady got us with the Patriots. But, I think Chiefs are still doing well and Aspen continues to do well. So the one thing I think is interesting about the agenda, if you look at how this has evolved, one thing that, a lot of people say, all we ever talk about is spinal cord stimulation, all our meetings, everything just spinal cord stimulation, and that's all you pain docs talk about. If you look at our agenda, I looked at it this morning, I was like, we don't have no spinal cord stimulation on the agenda. It just kind of shows you how the field continues to evolve. We're talking about things like minimally invasive spine, peripheral nerve stimulation, different techniques. So we're kind of getting into greater depth on a lot of these techniques and topics. So I think it's really cool to see, and it's cool to see all these kind of leading physicians associated with Aspen that are help leading this charge. Tim?
Dawood, thank you so much. And, we brought Chris Paul into this role because I think we needed someone really in a leadership role for these virtual programs. And, if your friends miss this program tonight, they'll be able to watch it via www.aspenpain.com. So that'll be great. And Dawood, I agree with what you said. The debates used to be about which stimulation company to use for the spine. And it's really evolved into which therapy to offer, which may include spinal cord stimulation, but it may include a lot of other things. And we're going to talk about that tonight. All 4 quarters of debate will be fantastic. When you look at the faculty we have tonight, the quality of people and the talent, the diversity, everything about the faculty tonight is just really encouraging to me. It shows us the shape of the field. The field is moving that way. It's moving to an idea of a thing. And the last thing I'll say before we introduce our president to give a few comments, Dr. Peterson, is that, really, I think I got so tired of seeing debates on LinkedIn. Many times anonymous people saying things that were really not very valuable, or people with no experience with the procedure, or maybe no experience with publication. And to get in an open forum and be able to debate things in a very pleasant, professional way, this is a way forward. And I think hopefully it'll be a good example to our younger colleagues, fellows and residents watching tonight. With that, I want to introduce our president, Dr. Erica Peterson, and have her give a few president's remarks. So Erica, can you join us?
I think Erica is having some technical difficulties. I'll say a few words as the past president. I think if Erica's technical difficulties correct, we will have her do the presidential update at the conclusion of the 4th quarter. But I think our society continues to grow. We're really excited about the meeting coming up this July in Miami. We've added a lot of new offerings. There's a pre-course course that's going to happen called Neurotech Horizons, where we're going to have startup companies and venture capitalists and having people from industry involved and kind of talking about some of their learning things. So it's going to be, we continue to broaden our offerings for everyone kind of involved in the space, and continuing to grow. We have a lot of really energetic young folks in our society, and we encourage all of them to reach out to colleagues, and there's plenty of work to be done. So I'll let Erica speak to a little bit more of this if her technical difficulties improve. But Chris, why don't you set the stage for the debate?
All right, thanks. So we have 4 quarters of action for everybody today. Me, Tim, and Dawood are going to be in the booth, as you will. But we've got some really spirited debates lined up here. As Dawood pointed out, it's kind of not the same old spinal cord stimulation, but really kind of minimally invasive spine and really kind of digging into the evidence. Each debater will have 3 minutes, and they'll have a chance for a 1-minute rebuttal. And we'll go back and forth, and then we're going to go to the sidelines, and we've got some reaction commentary from some really great participants, and really looking forward to everything that we've got lined up. So With that, I think we're going to turn over to Dr. Deer and Dr. Syed to moderate our first debate.
Wonderful. Thank you, Chris. And I want to say, and unfortunately, Erica's having technical difficulties, but the NFL study, which she really has pioneered for the concussion study, now is officially starting to enroll. And I think that's very encouraging. It took about a year to get the study design completed and get all the funding lined up with the NFL. So stay tuned for that. So you'll hear more about that soon. I think it's going to be a really important thing for post-concussion headache and post-concussion mental difficulties. So we're looking forward to that. With that, I'm going to bring on Dr. Buchanan, Dr. Bovenet for debate number one, and certainly discuss the issue at hand, clinical studies versus world data. With that, Dawood, we'll let you pose the first question to Dr. Buchanan, and he will kick off with his first 3 minutes.
So I think this is a really interesting topic. I think this, what they're debating today can be applied to pretty much everything we're talking about today, but specifically we're going to talk about sacroiliac fusion stabilization procedures. We all know that there's multiple ways to do this procedure. They all can be very effective, but how do you guide, what you're going to do for your patients? So two people I couldn't think that would be more qualified for this, Dr. Buchanan and Dr. Bovenet, are going to talk about link evidence, clinical studies versus real world data, and which should guide your treatment algorithm and approach. So with that, we'll have the first speaker start. I can't remember who was supposed to start, but whoever was supposed to start.
Thanks, Dawood. So unfortunately, my Notre Dame Fighting Irish took the loss yesterday, but winning this Super Bowl debate would be equally as rewarding. I know I'm going up against a tough opponent, better defense than Ohio State with Dr. Bovenet here, so I'm going to try my best. But I think there's three main reasons why clinical studies kind of guide my treatment algorithm, specifically in SI fusion. Number one is patient access. So if you look, before, usually you would do conservative treatment, physical therapy, sacroiliac joint injections, and then radiofrequency ablation. If that doesn't work, SI joint fusion. However, a lot of insurance companies have taken away radiofrequency ablations. Why? Not enough clinical evidence. So that has definitely shifted my approach from going from radiofrequency ablation to SI fusion, now going from injection to SI fusion. Number two is comparing other SI joint fusion companies when I'm looking at, what I'm going to be using for my patients. And you took a look at what was first, established, which was the lateral SI fusion, and their clinical study, the INSIGHT study, established the code for lateral fusion and was considered the gold standard. Fortunately, and full disclosure, I am one of the investigators of the SECURE study. The SECURE study by Paintech using the link, which is a single implant using posteriorly, created a study where they used, the exact same inclusion and exclusion criteria of the INSIGHT study. So you're kind of getting a apples to apples comparison of the INSIGHT RCT comparing the control arm with the treatment arm. And what that showed after a year is that not only is the SI joint link fusion equally as effective in both VAS scores and ODI, but also much safer. So when I'm looking to treat my patients, number one is safety profile. I'm looking do no harm. So that's another reason why I chose link. And number three is society guidelines. Tim and Dawood did a great job with the best practices of sacroiliac joint fusion. And one of the reasons why is because of the clinical studies done by Paintech and the SECURE study to base these best practices and clinical recommendations on this. So those three things are a huge reason that guide me through my treatment studies.
Great, Chris, you have 1 minute to rebut what Patrick just said, and then you'll have 3 minutes of your own to make your own argument.
I appreciate what Patty B said there, and I also was one of the clinical investigators in the SECURE study, and I respect that study. That's probably the reason why that Paintech and the link procedure posterior allograft showed that its safety and efficacy got their level 1 code. But I also want to see that it is reproducible in my own practice, obviously being part of that study, but it is also company sponsored study. So can we see that in the real world in a non-sponsored study? And we do, and we see that it is even can be better than those outcomes. I respect what Pain Tech did and what Link did, and it shows very comparable as far as the efficacy compared to the gold standard lateral approach to SI bone, and obviously a lot safer, but I think the outcomes can be better. Dawood and I talked over the years showing how our particular approach has changed over the years of doing Link. The last 5.5 years we've both been doing this. I think maybe even 6 years. I've done about 500 of the posterior allograft approach and several other lateral posterior oblique approaches as well, whether guided by insurance. So I need to see that it is reproducing my own practice, and I'll get into that during my next 3 minutes.
Okay, so great job rebutting there. Now, your arguments that the clinical real world data is more important. So you get 3 minutes for that, and then we'll hear Patrick's.
Yeah. As I said, we need to see that it's reproducible, and having similar outcomes, about 2/3 of the patients doing well in secure city is great. What I saw in my initial 50 patient cohort at 3 months, we saw an average, pain reduction about 76%. At 6 months, we're about 80% improvement. Now I had a consecutive series of 275 implants over the course of 208 patients, 67 which were bilateral. What we saw was an average pain relief of about 85.6%. We see that 98.6% of patients are reporting at least 50% pain relief, and they're doing better over time. We see it 3 months, 6 months, and in 1 year they're doing better. There's nothing else that I could think of that we do. And last time I counted, there's 91 different things I could do to treat pain across the pelvis, including the lumbar spine down through the greater trochanters. There's nothing that improves over time. Ablations wear off, epidurals wear off, efficacy of stimulators wear off over time. Nothing has gotten better. We also have a real-world study looking at 6 different clinical sites, including academic centers as well as private practice, and we have 439 total patients. And again, we see that improvement over time. The average pre-procedure pain score was 7, and post-op, the most recent follow-up, some out well over 2 years, was then a 1.98, representing a 72% reduction in pain. So we do see that we can reproduce this in the real world. And what I saw in my own clinical practice, with a caveat, with a modification to the standardized technique, we see all the stuff, as Dr. Deere said on LinkedIn, people debating, people missing all the time. And that's the biggest risk of the posterior allograft approach, is people are missing all the time. The study published last January, the 8 different variants of normal SI joint anatomy, and that's about 55% of the time you're going to see this. And those patients are more likely to have, chronic SI joint pain. So it's really, you're seeing 60 to 70% of the time, you're going to have these variants of normal anatomy. So the preoperative imaging that I've been trying to promote for years is paramount. And that's where I got those great outcomes, looking at those 255 patients. Just to reiterate, I said 98.6% reporting at least 50% pain relief at an average follow-up at 13.1 months. So not just 3 months, 6 months, but over a year on average. And the average reported pain relief is 85.6%. I had 3 wound dehiscence early on when I used to use Dermabond. We switched to staples and no other adverse outcomes, and those healed without any other interventions. So safety is there, efficacy is there, and the real world, reliable, reproducible with this preoperative mapping, was a game changer for me.
So, Chris, one thing you did, in part of your real world data, and then I'm gonna have Patrick the last minute, and we're gonna go to our analysis, but you developed a really nice way to use CT scanning to predict the approach intraoperatively. And, I heard you give that talk, and I think that was really innovative. So I just want to applaud you for that. I think that that type of thinking where you use CT preoperative imaging to guide the angles and things of that nature made your real world data so nice. And I think a lot of us can learn from that. And I know I learned a lot from that. Patrick, you get 1 minute to rebut or agree with the things that Chris just said.
Yeah, Dr. Bovedite made a great point regarding, there's always room for improvement in the clinical data. And I think CD guidance is one way to improve, patient outcomes, which is great. But again, at the end of the day, patient access, what all these coding and reimbursements are based on is level 1, level 2 evidence, like the SECURE study. So, just to wrap it up, there's a lot of great companies out there with SI joint fusion, some we're going to be talking about today. The first thing that I'm looking at in terms of determining which company I use and which intervention I use is show me the data. And right now, PainTech has the best multi-center prospect data looking a year out than any of the posterior fusion companies right now. So I'm looking forward to seeing what else will be out there. I commend other companies for doing that, but right now, PainTech has the best data out there.
Well, great job, gentlemen. That's a tough one. Let's bring in our analysts here, Dr. Vu and Modivala, to weigh in here. Soraya, what'd you think?
Wow, I mean, what a great discussion, first of all, and actually very synergistic between these two gentlemen in a lot of ways. I don't think any of us think there isn't an importance to clinical data. Clinical data is what gives our practice structure. It's what gives us guidelines. It what gives us reimbursement, insurance access for patients. But we can't ignore people's real world experiences. Our populations that we treat are very heterogeneous. Who Dr. Bovenet treats in his part of the country may be very different than Dr. Buchanan's. And to be able to see from such an extensive experience of Dr. Bovenet's, how it's actually been better, even better than the clinical evidence, just shows how much these things do have to exist together. And refining the technique as we go leads to better outcomes, and sharing that with your colleagues is really important. But at the end of the day, just like Dr. Buchanan said, our practice has to be structured on good, sound clinical evidence. So I don't know if I'm supposed to give this to someone, but I'm going to give it just a little bit to Dr. Buchanan, just based on that. But again, what Dr. Bovenet brought to the table was very strong.
Dr. Vu, Soraya's on Team Buchanan, so what do you got?
I agree with Dr. Soraya. I think that a hybrid approach where we highlight and incorporate both real world data and strong clinical studies is really important, because the clinical studies really allow us to control for variables and really give us a strong foundation for evidence-based medicine. And so on the other hand, the real world data, we can generalize it to more challenging or diverse patient populations. So I think they're both really important, but just thinking about where our field is going in terms of minimally invasive therapies, we're really kind of offering an alternative to a lot of these more open or minimally invasive, previously more invasive procedures. And so, I think it's really important to be able to establish our credibility with our surgical colleagues, with our insurers, like Dr. Buchanan was mentioning, but also to instill greater confidence in our patients and make sure that we're not, like we said, doing no harm. I'm gonna call it a draw and agree with both Dr. Buchanan and Dr. Bovenet, but I appreciate both of their viewpoints.
So it looks like, Patrick, even though Notre Dame lost last night, you had a small victory here, just by a field goal. Chris, great job. I think you made great points as well. Debate one is over. The first quarter ends 3-0 in a very close defensive struggle. So thank you all very much. We're going to debate number 2. Chris, we have a lot to live up to in debate number 1. It's going to be a tough one here. We've got colleagues. I'll let you start the debate.
Yeah, I think we've got a slugfest ahead of us. So Dr. Rahman and Dr. Latif, really looking forward to hearing your opinions about this. So I'm going to kick it off with Dr. Latif. Somebody comes through the door, how do you look for a first-line treatment for these patients? What patient characteristics are you looking for?
Yeah, thank you. This is a great topic, and I'm excited right now to make the case for why 60-day PNS for low back pain should be earlier in the algorithm as compared to radiofrequency ablation for appropriately selected patients. So first, let's go to efficacy. It has to work. In 2019, Gilmore published a study that showed that 67% of patients had an average of 63% pain relief at 12 months. In 2023, Dr. Gilmore and Dr. Deere published a study in IPM that showed that 77% of patients had improvement in pain, pain interference, or disability at 14 months. And more recently, there was an analysis of 4-year follow-up data from a multi-center prospective study that was submitted by Dr. Gilmore and Deere and presented at ASRA just last year that showed that 63% of respondents were reporting pain relief at an average of 4.7 years post-treatment. Now, what about PNS versus RFA? The RESET trial is a level 1 multi-center RCT that was led by Dr. McCormick and was presented at ASRA this last year as well. Medial branch PNS was compared to standard of care, which for axial low back pain, which in the study was primarily RFA. And PNS strategy was found to be superior across all primary and secondary outcomes. In fact, 60% of the PNS group had responders versus only 31% of the standard of care group. And in fact, the PNS group had a 50% higher rate of opioid reduction as a kind of a secondary benefit. RFA is also destructive. Dr. Deere and colleagues published in 2021 in Pain Medicine that the collateral effects of RFA include denervation, atrophy of the multifidus, and possibly other paraspinal muscles, including the rectus spinae. PNS has mechanistic advantages. RFA can often fail due to variant anatomy of the medial branch or failure to target the nerve precisely. Sometimes you have to be within a couple millimeters or right on the nerve to have successful ablation. PNS leads are much more forgiving. They generate fields as great as 3 centimeters, and this means it can also often overcome issues around medial branch variant anatomy, which is much more common than we often suspect. In terms of other applications, Dr. Chelsea Hoffman and Ryan D'Souza published in Neuromodulation in 2024 on diagnostic nerve block response not being predictive of superior pain relief with PNS as compared to patients with negative blocks. And so what this tells us is that when facetogenic pain is strongly suspected and medial branch blocks are negative, this is another scenario where 60-day PNS fits in very well. So what about cost? That's always important. In 2024, Dr. Schatz published in Pain Therapies on Cost Savings with 60-day PNS in patients with low back pain as compared to standard of care, other advanced interventions, and even surgery. And algorithms that prioritized initial 60-day PNS approach saved over $8,000 per patient in the first year of treatment. So in conclusion, 60-day PNS should be considered before RFA for low back pain in appropriately selected patients because it is more effective than RFA. It is more durable. It is non-destructive, and it is cost effective.
All right. Well, that was action packed right there. I think this is going to be hard to fight back on. So, Dr. Rahman, why don't you give us a rebuttal?
Dr. Latif, I knew it'd be a tough act to follow. You did not disappoint, my friend. You brought up a lot of great points here. I also am an advocate of peripheral nerve stimulation, including this product. And I want to congratulate all the authors that put out this excellent data that you brought forth here today. I'm going to comment on a couple of different things here. One is the RESET trial that is yet to be published. So I look forward to peer review. However, I want to say that they looked at RFA, therapeutic injections, and physical therapy. So the question that comes to my mind is, what are we actually treating here? What's the diagnosis? You brought up another great study that Dr. Gilmore and colleagues published that showed 4-year durability data. One of the things that I've noticed in some of the pain space when we talk about durability, our attrition rate is somewhere between 50 to 70% as far as responders that fall off. So we need to find a better way to optimize that data. And when you do talk about RFA, I think it's all about patient selection, optimizing outcomes, using the 25 gauge needle, single needle technique, use of dye, as well as a large bore RFA needle, and expect at least 80% success from the medial branch block. So a lot of good points, but a lot of room for discussion as well.
So now you get 3 minutes, Mansoor, to discuss your thoughts, and then the last minute, Usman will have to respond to you. So you're following a tough act, but I think you can do it. So I have faith in both of you.
So I just want to remind everyone that we're talking about first-line therapy for treatment of axial, back, and neck pain. First line is a very strong word. I'm a huge supporter of this therapy, and I don't think there are any limitations in this therapy as far as the software, the hardware, or efficacy. It does work, but is it a first-line approach is the question. The PNS system is very thoughtfully engineered. The reality is, in medicine, the needs of all stakeholders in the healthcare ecosystem must be satisfied. This includes the patient, the physician, hospitals, or our clinical practice environment, as well as the insurance payer. Patients simply want a therapy that works and that's going to provide them lasting relief. And there's good data that Usman just highlighted here. As a physician, we want to be good stewards of a therapy that we offer. And patient selection is certainly the key determinant of success for any therapy. At the present time, I don't believe there's good criteria for who would benefit from this therapy as it relates to neck and low back in particular. So there's many questions that remain unanswered. What are we using to find these patients? Is this diagnostic imaging? Is this physical exam maneuvers, diagnostic blocks? Are we treating anterior column pain, posterior column pain, or a combination of both? What are the specific diagnoses that we are using when treating this patient? Because none of my notes say neck pain or low back pain. They have a very specific diagnosis. So I think it would be helpful for future studies to kind of better classify the characteristics of responders versus non-responders. That would help me select patients. Anybody that's been to a pain society meeting has heard the plethora of data that's out there to support safety, efficacy, and durability. However, many private payers, the burden of proof has not been met, and the onus of that falls upon us. In the last ASPN guidelines that was published in 2022, it did a beautiful job of summarizing the data for this therapy. And in that very paper, it gave a level 1 grade B recommendation for the use of PNS for failed back surgery syndrome. When you look at the level of recommendation that was given for medial branch for axial low back or mechanical, it was a level 2 grade B recommendation. So certainly room for optimization there. In addition, I want to point out that there are certain limitations relating to the site of service for this therapy. This therapy cannot be offered in an office-based setting where many interventionalists practice. So when you look at folks that are offering this in a surgery center versus at a hospital setting, there are also certain economic variables at play as it relates to the utilization of a single lead versus dual lead. And the vast majority of my patients have low back pain that's bilateral or neck pain that's bilateral. So that's something that I certainly take into consideration. I think we should continue to publish good data, advocate for peripheral nerve stimulation in general, particularly through society-driven initiatives in order to get this therapy frontline. I do believe this can be a frontline therapy one day. I just don't think that day is today.
All right, let's see if you can pull it over the line here, Dr. Latif.
All right, Dr. Ahmad makes a lot of good points. I'm gonna try to hit a few of them real quick here. So he brought up about the reset data. It's true, in the standard of care group, there was a lot of different therapies that were permitted. The majority of it was RFA. So, in terms of comparison, there is a sub-analysis of just the RFA group, but we can't talk about that right now because it has to be presented at NANS and it'll be available after that. So I think you made a good point. Once it goes to peer review and available for publication, I think you'll see that there's a lot of really interesting points that we can draw out of that. In terms of patient selection, that is always important with every type of therapy that we use. You mentioned, that there are patients who have cervical pain or they have lumbar pain. There is a lot more publication on lumbar PNS. There isn't a lot that's outright on cervical. There are two that are coming around the corner. One is a paper actually that data we presented at ASRN is coming around the corner in the manuscript that I worked on with Dr. Francie and Dr. Lamb. And then there's another paper that's separate that's also coming out. So I think that's going to bring a lot more to the field. But when you talk about how do we select which patients, it'll help kind of break that up because we looked at a lot of different subcategories and helped guide that.
Gentlemen, that was a lot of data in about 8 minutes. So I'm really impressed. We're going to bring our analyst on now to give us an analysis of how you did. And we have some great colleagues, Dr. Ha, Dr. Murphy joining us for the reactions. So doctors,
Yes, that was fantastic. Great job, Dr. Latif and Dr. Rahman. So, I was taking notes when you guys were saying all that. I was thinking the personalized therapy, right? There's no one cure that fits all. We got to personalize the treatment option, whether or not it's first line or second line based on patients and what they need. And I think one thing that many of us will hear this every day is our patients will say, I don't want to just mask the pain. I don't want steroid. I don't want to just burn the nerve. I want to treat the underlying cause. And you brought up a really good point, Dr. Latif. I mean, are we treating the root cause of pain by stimulating the nerve, given that we're not burning anything, we're not putting steroid, we're not doing a nerve block? So that's something certainly to consider. And one other thing is, if you think about the process of getting patients approved for the MBB number 1, 2 weeks later, number 2 in RFA, it takes about a month to get anything done, right? So if we have a way just to put some leads in and give it 60 days, is that more cost efficient? Like, can we save more time in our surgery center in office that we can use that time to take care of other patients? It's just really intriguing to think about all these options. Maybe one day we'll shift the way we think about the first line treatment option for many axial back pain patients. And the other barrier I know many of us are thinking during the debate is insurance approval. I just hope that one day we can get more access to the care that our patients truly need, something that's evidence-based, that's effective, and not dependent on insurance. Dr. Ha.
Yes, excellent job, Dr. Latif and Dr. Aman. You know that I am personally a huge fan of peripheral nerve stimulation, but I like all of the points that have been made. I think we have to be really careful when we have exciting new treatment options that we continue to try to offer them to the correct patient. So I think patient selection is going to be key to preserve the therapy. We definitely want to be a little bit discriminate as we build this evidence base that Usman's been referring to, so that we can get this therapy to as many folks as possible. You know, first line is a big deal. And I think Dr. Aman made a good point there that, you know, what is first line therapy? And obviously we want to include always our conservative management, physical therapy, pain psychology, make sure we're using our biopsychosocial approach. But I think it's going to come down to timing. We don't really know exactly when we should be offering PNS versus the radiofrequency ablation, but hopefully all of our mounting evidence will be important in terms of, you know, what are the biomarkers that we're looking for treatment response. We are developing those, looking into different radio tracers to try to really localize the pain and try to make sure that the therapy is reaching the correct patient. But these are all, you know, future considerations. I'm excited for the space. It's great to hear about what's coming down the pipeline. I want to see the results of that, the RESET trial. The other thing too is a lot of times we put these interventions in a category of let's wait and see, but I think some of the interesting findings that I've seen is that we're affecting all outcomes. I think, Usman, you referred to this, you know, the improvement in quality of life, the decrease in depressive symptoms. And so maybe we don't have to be as discriminatory, and just the fact that this is treating pain so well is having such a good collateral effect. But overall, great job, guys. I think there's a lot to do in this space. There's a lot of research coming down the pipeline in many different directions. And I love where we are with this therapy. I don't want it to see it go away, and hopefully we can all continue to advocate for it.
All right, both of you did a great job of analysis. So who won the quarter, Dr. Latif or Dr. Aman?
Ohio State, OHIO. Just kidding. Oh, gosh. I'm gonna say it's maybe just like a little bit towards Usman. That's what I'm going to vote for.
I think they both did a great job. I mean, I think they're tied. I mean, I really like both of their debates.
So so now it's 6-2. So a field goal win by Usman there. So it's 6-0. The first debater winning both debate by a field goal. So thank you all very much for this debate, and we'll move on. We have a halftime report by three of our executive leaders, Dr. Chakravarthy, Dr. Peterson, and Dr. Pope. So we're going to give it over to y'all for a few minutes here.
Thank you very much. And again, apologies for the technical difficulties earlier. I missed out on the first little part of the first debate, but the theme of the night is the importance of evidence and understanding the evidence. It's not just about watching the shiny handouts that come through the front of our offices. It's really about spending enough time thinking in depth about where are the primary endpoints, what does this actually mean, what are the impacts, and it's beyond the clinical trial to real world evidence as part of that too. So there's some real challenges in that, but Chris and Jason, you've been leaders in our society, you've been leaders in this pain space as well in terms of bringing devices forward and advancing what we can do to help patients in terms of these outcomes. Chris, what do you think? Where are we in terms of actually the biggest challenges in trying to build this evidence and create a perpetuation of this exciting momentum as Dr. Ha was talking about during that wrap up?
You want to start, Jason? Because I was busy counting some interesting facts about the debaters. I didn't realize that Chris had a video on Facebook where he can dunk. And I was like, man, that's got to go for some points. I don't know if you guys seen this. He can throw up a mean layup in a dunk. So I was trying to pick my winners this part of it. But no, but I mean, look, I think, you know, we are, as a specialty, we've done an amazing job collecting a ton of evidence. I think the question that is really plaguing us right now is, what do insurance companies really want to see? And I think a lot of it is therapy preservation as a part of it. You know, there's certainly some parts of, as we mature into a field with more therapy options, comparator trials is how a lot of different specialties started to look at how objective data across different therapies lead to better or worse outcomes, or more importantly, kind of getting to the point where you're seeing a lot of pushback from insurance companies on what are data they think is meaningful. So I think it's important to really on whether it's real world or data that we produce that gives us clinical utilization and confidence. I think it's a really good time to start reflecting on each therapy by indication, and then really tailoring it to maintaining efficacy and kind of reimbursement. That's a really big part of it. Jason? I don't know if you have-
Yeah, I'll jump in here for a moment. Kind of in regards to data, I mean, I think we all can appreciate that data is the currency in our space, and it opens the doors and shuts the doors for access to therapy. As Christian pointed out, I think that payers pay attention to data, whether it's good or bad. And there's a lot of headwinds associated with quality of data. There's headwinds associated with randomized prospective multi-center studies. And there's been a big push through FDA on leveraging real world experience in large cohorts of patient populations. And this concept is nothing new. We've talked about it at ASPN in Nashville. We talked about it at ASPN in July, last couple of times. And I think it really is the time as a space and as a society to think about collaborating retrospectively, collecting the same data in some sort of registry fashion. We have talked about it till we're blue in the face, and I think that it's time to really consider this, because let's take some case examples, right? The first debate was on sacroiliac joint fusion. That's a hot topic. A lot of us know about it. It's a really hot topic based on where you are in the country and what therapy you're reaching for. There's either silent non-coverage or silent coverage. That's an issue. We have done it. We think that it works. We have data to validate that it works. There's only been one company thus far that's produced prospective data out to 12 months. That's a problem. So we certainly need more data that's acquired in as a study where we have authorization from an IRB. So it's not done as an exemption, it's done as an approval. But we are the stewards of our space right now. And I would say that our space is very in a precarious spot. So if we don't pay attention to acquiring data, whether large cohort retrospective study or prospective done in a quality fashion, we're going to lose access to these therapies. So that would be my commentary on how the debates have gone so far. And I loved all the data in the second debate. I'm a data guy. I don't know that I can speak that quickly. My son listens to this rap song by Eminem, and there's this like section that's like really fast. It's supposed to be like the fastest rap ever. I would say that they're competing with that. So that was really good.
Yeah, I think that with the question on this is, you know, the goalposts that keep moving on us. And how do you chase this when you get to a place where we have to keep creating better and better data sets as the goal line is looking further and further away? And so part of that is having the right strategy and keeping our focus on what the mission is, which is to maintain access to the best quality therapies for our patients as part of that. You know, we're starting to work on using ASPN as a research network. That's part of what we're doing with our pilot, looking at the funded grant through the NFL for post-traumatic headache. And so that's, again, somewhere where if we can show that ASPN has the ability to pool data across multiple sites, then why shouldn't we do that in a pooled fashion for all our participating sites for other indications as part of that? So I'm really excited for our NFL project because I see that as a pilot for how we as a society can lead in a lot of ways and hopefully do it with a very streamlined infrastructure.
Yeah, I'll jump in here real quick and say just one more thing, and then I'll pass it over to Chris for introduction. I do think that one of the important things that our society is doing is education. And when we look at the things on the debate, there's no real ACGME accreditation for surgical training, specifically for these minimally invasive things. So that's something we need to work on. Chris, I'll hand it over to you to introduce Dr. Deer and Dr. Sayed.
Yeah, I just got to say, the last time I did this, the Bills should have won. I got to believe this is their year. I think Josh Allen's going to go all the way. There's a famous saying in Buffalo whenever they play in Miami, it's called squish the fish. I just found out the mascot for the Chiefs is a wolf, so it's going to be the wolf here. Let's go Buffalo. That's all I have to say. I'm going to hand it over to Tim and Dawood. I think this is the year they're going to win the Super Bowl, so I'm rooting for them. Anyway,
Enjoy this week. Enjoy this week, Chris, because it's the only week you're going to have of happiness.
Your halftime report was fantastic for all three of you. Your comments. I will say though, you both enjoy it because next year when the Cowboys bring Deion Sanders, you'll be proud. Cowboys will be back. But anyway, I got my Cowboys colors on tonight, so we'll see. But anyway, thank you all three very much. That was fantastic. Loved everything you said, and look forward to discussing this in Miami. And as you know, we're going to create a MIS certification program, Jason, with your help and that of Chris and Erica and the whole team. And so that's going to be our next big step. And Stephen Pawlowski will be a surgeon leading that with us, along with some of his colleagues like Dr. Dorsey and Dr. Montalva and others. So with that, thank you all. I think our next debate is going to start now.
All right, well, into the second half now. So really great halftime analysis by three, I guess, two former and current and future presidents. So really, really cool to see that. So quarter three debate, we're going to be talking about facet joint fusion link, something probably a lot of folks don't have a lot of experience with, something that I've done here for a few years now, and I've been very pleased with it. And I think it's primed to kind of be the next big thing. So we'll have two leading thought leaders on this talk about it. They don't really need an introduction. So gentlemen, I'll let you take it.
All right, so I'm going to start with the first 3 minutes. I'll say that this reminds me of going back years ago when I did the first Vertiflex as a non-surgeon in our study, when we did the first Vertos mild cases as non-surgeons. And you know, really talking to my surgeon today, John Orfanos, who I work with very closely, he was skeptical about percutaneous facet fusion, and I was too. Matt Ranson, who's in Arizona now, was with me years ago, a great young man, and he did a few cases in West Virginia, and they were bone dowels, and they fell right out. And they had very poor outcomes. And I think that's what we all associate. But the newer products, and again, we're working currently on some research that would be, I think, 510K approved very shortly. They're miniaturized. They're formed so that the actual access to the joint is much safer, and there's a safety stop. One thing Dr. Pawlowski is probably going to say in his 3 minutes is they need to be safer, and I agree with that totally. We have to have a safety stop that stops us from going through the joint. Very, very important. And I think the other thing about it is sagittal balance has really remained captured. If you have patients, we talked about SI joint earlier, when you do a large pedicle screw fusion, we know that we see those people back in a few years with sacroiliac joint dysfunction. I think we can maintain sagittal balance and decrease some of that, and we can maybe reduce the disease above and below the fusion. It would be quite fantastic. We've done some early analysis of some of the new devices, and Dr. Pawlowski couldn't take them out neurosurgically without taking the joint out. That's how much stronger it is, about 357% stronger than predicate devices to be in the joint. So all those things are fantastic, but I think there's 3 things that Dr. Pawlowski should point out that I think he probably will. One is we need an education track to really make sure that people do MIS safely. I think that would be part of any approval of any new 510K device. We should go through that process. 2 is we need a registry outcome device, because there's only right now very scattered studies in this. We need a level 1 study and multi-center and a registry once we get approval for these types of devices to assure continued safety and efficacy. And then I think we need cost utilization. And then what we're seeing currently with all the MIS things we're doing, we're seeing improvement in healthcare utilization, which is Jason said, data was our currency But I think healthcare utilization will be our other currency. When you can do a procedure with minimal blood loss, minimal complications, people are out of the hospital facility very quickly, and we have a low readmission rate. So those are all things I think are really exciting. I think we are in the era where we were 15 years ago with Vertos Mild, where we were 15 years ago with Vertiflex. And people like Dr. Pawlowski helped us go through a multidisciplinary approach to doing the research we needed to do. So I think that this is going to be a debate that we both agree there's work to be done, but the new predicate devices were good, but the newer devices coming along will take that next step of minimally invasive, easy access, great tools, and hard to remove, which will mean stability. So with that, Stephen, I'll give you the next minute, then you can have your 3 minutes.
All right, nice job, Tim. So for the 1 minute here, there are things that I'm definitely going to agree with you on, and one of those things is that, I think facet fusion is here to stay. I think it's going to be a hallmark for interventional pain and interventional spine, but I do think there's certain things that are missing right now. And when I say missing right now, I think the current products that are on the market do address some or don't address some of the safety issues, the idea of having a positive stop. And as you alluded to with Aurora actually working on a new product for this, they're trying to address a lot of those issues. But I do think we're still going to have the barriers that we've had continuously for years now, meaning we're going to have data to support what we do. And then more importantly, though, too, is I think we're going to get some pushback again from the surgeons, as we've had for almost every intervention we've been trying to build over the last few years. But I do think that facet fusion is going to have a place, and it's more than just a missing link for this.
Nice rebuttal, Stephen. Let's hear your 3 minute con.
Okay. So I'm thinking about like my chances of winning this debate when I'm actually pro facet fusion, and especially against Tim Deere is, it's like taking on the Chiefs right now. But being from the Northeast, we have 3 shots. We got the Bills to take them down, and if they don't, we got the Commanders or the Eagles. So I got 3 shots that the Northeast can still do this over the Chiefs. So here's what I have: 3 pillars now that I'm going to try to take Tim on with. The first one is the safety aspect. That we know that with present facet fusion devices, there's concerns about pullout of the screws. If these screws are malpositioned and or pull out, or can they be retrieved by the interventional pain physician and put them in? And then the other thing is having a positive stop. At present, we don't, which means if you go too far, you have to worry about the foramen and the nerve root. So that's my first pillar, is safety. And my second one is going to be efficacy. Right now with facet fusion, we really only have industry-run biomechanical studies. We actually don't have any clear clinical studies to support facet fusion. There's some early work done with cervical implants done many years ago by surgeons, but even those facet fusion devices were actually placed open. So right now we're lacking a lot of the clinical data that we need, and we're basing the idea of this facet fusion largely on bony fusion data that we have from surgeons, as well as pedicle screw fixation data. What's interesting is even if you look at facet fusion over the last 15 years, the devices that actually usually did facet fusion were transarticular, so they went across the facet joint. Now we're looking at devices that are intra-articular, so we're actually even changing the direction of approach and how we're trying to fuse the joint, and still do not have evidence for that. We also don't know what the long-term effects are of fusing facet joints. Is there more chance of adjacent level disease? Is there less chance of adjacent level disease? And then finally, the third pillar I wanted to get to was indications. So it is not clearly defined. I can tell you, even as a surgeon, it is not clearly defined who the perfect candidate is for facet fusion. Obviously, we probably will all agree that facetogenic pain is an important aspect of it. But the way I actually look at it when I look at patients is, if I can't do something like, say, an interspinous fusion, because they've already had the spinous process removed or the lamina removed, I start looking at things like facet fusion. I think of things like adjacent level disease or facet pain after a kyphoplasty. You can also think of it as hybrid approaches where you can back up interspinous spacers or interspinous fusions by also fusing the facet joints. But I think the important aspect there is that we don't have clear indications of how to actually use these devices. But the one thing I will end with is that we do need it. We have an older patient population who can't go through pedicle screw fixation. who are going to have facetogenic pain. They're going to develop adjacent level disease 10 years after their fusion in their 70s. So we do need this device.
Well, this definitely lived up to my expectations. It was three yards in a cloud of dust, but we're going to turn over to the analysts and get their opinion. Oh,
When I get my rebuttal, Dr. Paul.
Yeah, you get 1 minute.
I'm sorry. I didn't mean to cut you off, boss. Go ahead.
I just want to have 3 points. One is, Stephen's right. We can't fish it out if we miss the joint. Also, neurosurgeons can't treat an infected disc if they have an infection post-surgically. They have to call in their infectious disease colleagues. So that's why we are a team, and I think that's how the future is. 2 is, I do think that backing up things like a minimally invasive fusion, whether it be percutaneous lateral or whether it be direct, is a great potential option here. And people with kyphoplasty, we know they all have facetogenic pain, and then spondylolisthesis is grade 1. So there's so many indications here that I want to look at studies. So I think we agree the studies are needed. The safety looks like it's going to be quite improved with the new devices. And then I think at the end of the day, it's going to take a teamwork. That's why we none of us can do everything. That's why we have to do it in a team approach with a surgeon, interventional spine people working together. So I think that's my rebuttal. I think we tend to agree more than disagree. Now, Chris, you can bring in our analysts.
All right, now we're going to bring in the analysts. A little premature there initially, but let's bring them in. Dr. Vu, Dr. Murphy, and Dr. Bailey-Classen.
That was great. I love how we have a surgeon telling us what not to do. So thank you, Steve. So, I think we're just getting started, right? I would love to revisit this in 5 years and think back on this day, this debate that we have, and think about how far we come in the journey that we have in interventional pain and spine. This is truly a fascinating new concept. Again, right, kind of like what we talked about before, a lot of our patients are complaining that we're just masking the pain, we're just burning the pain, we're just doing steroid, we're just trying to take your pain away with opioids. But if there's a way we can fix the issue, I think a lot of people will be really supportive of our treatment options. Now, it's another whole point of collaborating with our surgeon colleagues, and that's truly the theme of this year of ASPN, of the annual meeting, is we're going to bring everyone together in the same room and have honest discussion. We're going to learn from each other. The pain doctors will learn from the surgeons and vice versa. At the end of the day, what we do is the best for the patient. It doesn't matter if it's minimally non-invasive or surgery, whatever we can do to make our patients better. So I'm hoping that one day we'll have access to these interventional techniques that's in a safe way, and we have great data to support it, we have payer support, and we can better serve our patients' community.
I have to say,
I would agree.
a winner between this unbelievable discussion is, needless to say, a bit difficult. I do have to commend you, Dr. Deer, for highlighting the fact that we do need a registry, we do need to follow these outcomes, and we do need to have the data behind us to show that these products are safe and efficacious. I agree, we need to have the safety behind it. So Dr. Pawlowski, I second everything you said as well, especially with the long-term effects. These are newer, and so we've not seen them in patients for a prolonged period of time. What are going to be those changes as we see down the road? But a true winner in this debate, I'm going to have to call it a draw. And Dr. Deer, fingers crossed that Deion Sanders could whip the Cowboys into shape. That's all I'm going to say about that.
That'd be great.
I agree with Dr. Murphy and Dr. Bailey-Classen. I think, this device offers a really incredibly promising option for patients with facet pain, and a longer term option rather than just our temporary, radio frequency ablations. Luckily for us, I think Dr. Pawlowski and Dr. Deer kind of melded towards the end there, and they both kind of agreed with each other. So I don't know that we have to pick a winner, but I think that having data to look at long-term outcomes, really kind of guiding our patient selection and our ability to see what the potential complications are, so that we can be prepared to adequately handle those as the patient's surgeon. Is going to be really important moving forward when we kind of decide how to incorporate this into our practice.
All right. Well, I think it's pretty close here, but I think I personally am going to give a little bit of edge to Dr. Pawlowski. I think he put it off there. Maybe I stole Dr. Deere's thunder a little bit there with the rebuttal. I don't know. There's a little interference, but I think we'll give a little edge to Dr. Pawlowski. All right. And so next up.
So that was I think the Kansas City Chiefs always get little extra care, and it looks like that here we had extra care from Chris towards this as well. So Chris, kick off this debate for us here with our colleagues, Dr. Katri and Dr. Williams.
All right, yeah, so Dr. Williams, Dr. Katri, so we're going to be discussing lateral approach versus posterior lateral fusion here. So Dr. Williams, kind of want to kick it off to you to kind of start when looking at these patients, how do you decide when and where, and kind of guide us through your thought processes there.
Yeah, absolutely. Well, so yeah, final grand finale here. So hopefully Dr. Katri and I don't disappoint. But yeah, to me, the primary driving factor, why I think the lateral approach is arguably the best approach, is safety first and foremost, right? So no matter what the patient has, it's just what you're actually doing. So again, we're coming this way, right, through the spinous processes, safely away from all the neural frame and all the neural elements, right? So when you actually take the time to explain that to patients and they understand the safety and the rationale for why you're doing what you're doing, they appreciate that and they have confidence in not only the procedure, but you as a physician as well. Because I'm taking that approach away from all the important stuff, as I like to say, right? We don't need neuromonitoring because we're destructing less tissue, right? Again, no matter who the patient is, it just makes the procedure more safe from that standpoint as well. Again, it depends on what anatomy you have remaining, but I like to think in terms of the preservation of the anatomy, right? So I would argue the lateral approach is irrefutably the most anatomic preserving approach. Again, like I said, with that approach, we're preserving that supraspinous ligament. We're preserving a good chunk of the interspinous ligament. And so the question is, well, why does that matter, right? And so we all have native anatomy. I like to think it's there for good reason, right? It's like if your spine is a Jenga set and you start removing a block here and there, that's not without consequences. So I don't like to think about the patient in front of me right now. I like to think about that patient in the future. If you delve into some of the biomechanical studies, long story short, is that those posterior ligaments, again, chiefly that supraspinous ligament, contributes 40% almost of posterior spinal stability, right? It's the #1 spinal anatomic element that actually counteracts forward flexion. So it's not an unimportant ligament by any means. So I think the takeaway from all these anatomic studies, these biomechanical studies, is that we should all be maybe a little less cavalier or a lot less cavalier before we sort of just flagrantly go through that ligament. Again, thinking about our patient in the longer term. At the end of the day, it's not just about the ligaments, it's also about those paraspinal muscles, right? And I think at the end of the day, with a posterior approach, you have to mess with those muscles, right? And hopefully you're not frankly detaching them, but even if you're just sort of retracting them and irritating them, we know that that can lead to iatrogenic injury. We know that that can lead to, in the short term, probably more post-procedural discomfort, but arguably more of that multifidus atrophy over time, which, as we discussed in the previous debate, is a big problem with axial low back pain. I personally see too many patients that come in with that forward stoop posture in a lot of pain, right? So if I can not exacerbate that in my patients, if I can, preserve those important ligaments, if I can preserve those important muscles that maintain sagittal balance, right, that are there for good anatomic reasons, I think that's a victory. So to just kind of conclude my quick point, right, I'll lean on studies from, really smart people like Dr. Deere, who's here with us tonight, right, who showed pretty convincingly that this is a ridiculously safe approach. This has you can do some really great things. You can get like 50% reductions in pain scores, and you can get a very high comparable, like 93% fusion rate with this procedure. So it checks all the boxes to me as far as efficacy and safety. So I guess what I'm saying is I pity the fool who uses any other approach other than the lateral approach.
All right, Mr. T, shots fired here. Let's throw it over to Dr. Katri and get a rebuttal from you.
Yeah, well, first, Dr. Williams, I think excellent points here, right? I can't necessarily disagree with you on much of what you've said, but I do think that there is a very important thing. Someone want to start the timer, by the way. Otherwise, I'll just keep talking and talking. But some key points that I do want to bring up. First, I do want to say this is maybe even a continuation of the prior debate, because a lot of what can be said about the facet fusion as a relatively novel procedure in our space, right, is something that we can talk about when it comes to interspinous fusion and posterolateral fusion from a lateral approach as well. The key thing here is that we really do need more clinical data, right? We need real world studies. We need prospective RCT data as well to actually support these studies, especially when it comes time to talk to our surgical colleagues. That's one. The other thing is, while we do have good safety and fusion rate data and stuff like that, what about pain relief data? Patients come to our clinics not because they're looking for, hey, I really need the spine fused, right? They're coming there because they're in pain. And so do we have the long-term data, and are we working on collecting that data? I think that's really important. And I'll kind of leave it at that.
All right, that was a good rebuttal there. So let's kind of launch into kind of your viewpoint here, and let's kind of get this ball rolling with the other side.
Absolutely. So again, as Dr. Williams mentioned, all the pros and all the things that I don't disagree with, right? But I think that there's an entire part of this procedure that we're really leaving out, and is the real world part of it. And I don't mean the real world data or anything like that, but I mean really incorporating this therapy into our practices. And if you go around and you talk to most pain physicians out there and you talk to them about the Minuteman procedure, and just as we did years ago when it came to really getting acceptance of the mild procedure, there's one thing that a lot of people, especially a lot of pain physicians, kind of worry about. And it's how, I don't want to offend my referring surgeon, right? Having that sort of delicate, kind of balance with your consulting physicians can be really difficult, right? And it's a very realistic challenge that people have to deal with. And so I would say navigating that political aspect is a significant detracting factor of the procedure. And it's something that I think that together we really need to work on as pain physicians to make sure that this therapy actually is available to the patients who we serve. The other thing is, insurance is unfortunately a very real part of our lives, and it's really real part of when we're in the room with our patients. Sometimes I jokingly say to patients that the third person who's not really in the room but is in the room with us is the insurance company, right? And so unfortunately, I've had many instances in which I recommend the lateral posterolateral fusion for patients, interspinous fusion, and it's rejected by the insurance company. And I think, again, when it comes to the real world data, these are the things that we're going to need to do if we really want to be serious about promoting this therapy in a way that's actually accessible for many patients. And finally, I think another thing that's really worth saying is that if we're talking about the lateral approach here, this is an approach that really is not really doable at the L5-S1 level. And that's an area where a lot of patients have degenerative disease. And just knowing the biomechanics of the spine, it's not surprising that a lot of patients have L5-S1 pathology. And so it's just unfortunately not a realistic consideration, both because of the iliac crest that's difficult to come over when you're coming laterally, as well as the fact that most patients don't have an S1 spinous process that is of any significant, kind of robustness in order to be able to latch on an interspinous device to. And so in summary here, the political reality of the world that we're living in with our consulting and our referring surgeons, the world of private insurance companies, as well as the L5-S1, those are the sort of my main points there.
All right, so we're going to give Dr. Williams the last word here. Bring it home for us.
Can do, yeah. So again, hats off to Dr. Kotcher, because I really can't disagree with anything he said. I struggle with all those things that he just said, L5-S1 problems, try to navigate the world of who are your friends and maybe not so much your friends on the spine surgery side of things, battling with health insurance companies all the time because you do believe in this therapy for all these good reasons. So I think to maybe not refute what he said, but maybe sort of extend what he said, right? I think there are when you are approaching these collaborative discussions with your neurosurgical colleagues, right, there is data out there, and I agree, I wish we had more prospective data, I wish we had more definitive data, but right, you can look and say, hey, compared to a laminectomy, maybe this lateral approach is comparable, right? And if you can get all the same benefits that I just alluded to without having to destroy so much large tissue and not have to do that, well, why the hell not, right? So I think those are maybe for what we have now. I think there is data that we can maybe extrapolate from and or look, but I agree. I think having data-informed conversations is the key, and collaboration, as we've all said in all these debates, absolutely is the key. That's been the key to my practice, and I think it's the key as we move forward as a specialty, but as sort of an interspecialty discipline.
Could not agree with you more. Data really leading our specialty, bringing us forward into the future and kind of driving therapies and improving patient lives. So at this point, I want to bring in our analysts, Dr. Motabala, Dr. Ha, and Dr. Bailey-Klassen. Wanted to get some feedback and some analysis from the sidelines.
I think that was an excellent discussion. Again, I mean, everybody's been so great tonight and so educating. I mean, I learned so much from everybody at these debates. There is no doubt that this is a very safe, truly minimally invasive approach. There are other interspinous fusion devices that are a little more of a mini open approach and require more tissue manipulation. And that, maybe is something that is right for some patients and not right for others. And I think this, again, will come down to patient selection, ultimately, who this device is best for. Dr. Caffrey brought up the excellent point that a huge portion of our patients, with degenerative spine disease, it happens at L5S1. And this is not a therapy that's really meant for that. And so there's a whole subset of patients that this won't be available to them. But I do think going forward, part of our job is to publish which patients are best suited for this. What does their pain look like? What does their MRI look like? How can you best use this so that we're using the right therapy and the right patient to have great outcomes so the therapy remains available to all. But you absolutely cannot argue with how safe this is and how minimally invasive this is.
Oh, well, kudos to Dr. Khatri and Dr. Williams. I can't agree more. I felt like the running theme here was the practical arguments on both sides of the fence. Dr. Williams, I love that you brought up, just the preservation of the ligaments. And I don't think they get enough attention, but, preserving like the supraspinous ligament and pelvic floor stability is so key for so many factors. Dr. Khatri, I think you really hit the nail on the head with the theme that we do need more data to bring, this practical, what seems practical and safe approach to more patients. And, it's going to be a challenge either way with the politics, but again, hopefully we can band together and create some good data in this space so that for the patients that would qualify for such a minimally invasive approach, it will be available in the future.
So gentlemen, great discussion on both points. A couple of things I want to highlight. I do think ASPN has done a brilliant job of bridging the gap between the two specialties of interventional pain and stepping into surgery. And I think this is one of those procedures that really starts to showcase that. This is definitely a procedure where you have to have collaboration with your surgeons. So you're not offending anybody. So you can have that discussion beforehand before you integrate any of these procedures in your practice. I do agree. We need data. We need long-term data. Just as I said about the facet fusion, I think long-term data, long-term outcomes, and how these procedures are doing well for our patients. And on top of that, to be able to keep the therapy, we have to keep an eye on how we are billing out procedures and how these procedures fit into our current CPT code book. So I think those are all important things moving forward. Ultimately, whatever procedure you want to pick, I think it also, Dr. Multiva brought it out to patient selection. I think it's also provider selection. What way are you most comfortable as a surgeon providing that patient the best outcomes possible? So I think moving forward, those are all things that are vitally important to keep in mind. But overall, great discussion.
I really could not agree more. It was a fantastic discussion. From up here, it seemed like Dr. Williams was ahead, but I'm going to have to give it to the ground level folks and see what y'all thought. Who would you hand it over to? Is it Dr. Khatri or Dr. Williams? I'm going to put you all on the spot. Dr. Motabala, what do you think?
Oh, it was very close again. I'm going to give it to Dr. Khatri, though. I thought he brought up some very important things to think about. Not that Dr. Williams was wrong in any way, shape, or form, but I think he brought us up some some thoughts going forward.
Fantastic. Dr. Ha?
Oh, this is very tough. I'm kind of side with Dr. Williams. I'm really excited for this minimally invasive approach. I'm optimistic. I think we can come together with our surgeons on this one.
Fantastic. Okay, last word, Dr. Bailey-Klassen.
While I agree, we have to come together with our surgeons on this one. I'm actually going to lean with Dr. Khatri on this one. I thought overall he brought up some great points.
All right, so I guess it's Dr. Khatri with the win in the end. All right, well, thank you all so much. I really appreciate it.